All right, so I'm just going to briefly review the IASLC. I think everybody knows that the International Association for the Study of Lung Cancer has been around now for 50 years. And we have currently about 9,500 members. We are the only international multidisciplinary cancer organization. Now, a few years ago, we did shore up our mission statement and our vision statement. Our mission statement was really long, and so we shored this up. It's now to be the multidisciplinary world authority on lung and other thoracic cancers through collaborative science, education, advocacy, in order to ensure optimal prevention and patient care. And we've never had prevention in our mission statement ever before, so FYI. It's there now. And then, of course, we put that timestamp. We really want to conquer thoracic malignancies in the 21st century. And so all of you here, I think, are on a great start to do that. We have a new strategic plan that goes along with the new mission and vision statement. And here it is. Traditional 3 pillars: collaborative science, global education, promoting accessibility to multidisciplinary care. Each of them stand independently alone, but you can see how very nicely they flow from one to the other. And within each of these pillars, it's very important that we have that multidisciplinary collaboration that we're known for. We support our members. We are inclusive of the world, and we have that commitment to our patients. The work engine of the IASLC is our 14 committees, and the ones highlighted in red are the new committees. And so I'm very proud that we now have a multidisciplinary clinical science. We have a basic and translational science committee. But one of the things that I need, and I'm going to have a plea. I think most of you are involved in the IASLC, but we really need a stronger radiology voice within the IASLC. We need radiologists on really all of these committees. And I will say that when I have talked to the board recently, they value you. And I think you're going to see that in a few weeks from now when our board elections come up. So I just want you to know that you're valued. We appreciate you, but we need a stronger radiology voice within our community that I think will just take us to the next level. Now, we're here to talk about staging, and our staging project does fall under the Multidisciplinary Clinical Science Committee here, just FYI. Now, you all know that the IASLC has been responsible for staging. I would say it's really the crown jewel of what we do beyond the World Conference. And we've been doing this for over 20 years. We started with that 7th edition, 8th edition, 9th edition. You can see the numbers of cases that we have. And for the first time in the 9th edition, we did include some molecular data, which is under analysis, and actually the publication is at JTO. I'm not going to belabor this, but to say that this is what the database was made up of. I think you can see here that a lot of patients came from Asia. Thank you very much. Europe, North America, Africa, and the Middle East. But I think you can see we need to get a more equal distribution of patients going forward. And we collect the data via 2 mechanisms. One is the electronic data capture, which is the ideal mechanism for us to do that. It's individual data versus the batch data, which we have a lot more of. As you can see, over 100,000 patients came from that batch data. The quality of the batch data isn't quite as good as putting it in individually. So lessons learned here. The changes in the 9th edition, you already know these. The 9th edition was approved by AJCC in December, earlier than we had anticipated. It was a very nice Christmas surprise. We are waiting for the UICC to do so as well. But the changes really for us, we're talking about early stage disease. The mediastinal disease has now been subclassified into one mediastinal station versus a multi-station mediastinal disease. And I'm not going to go through the metastasis one. The key here is downstaging, okay? So you can see that 2B in the orange color is now 2A, and then you can see the 3A being subdivided. Half of them with the single station is going to be 2B versus 3A. So key here is downstaging in early stage disease. All right. What's next? We're now working away on the 10th edition. And number one, we have a new statistical center. For those of you who may or may not know, we worked with a statistical center called CRAB in the United States. We worked with them for a long time in SWOG, but we've now changed that to an academic institution. Had an RFP, and the University of Padova, which is known for working with large databases. I think they're going to be amazing. They've already been a great partner so far. So I think that's a real plus for us. As I already mentioned, the global representation. We need to be more not so one-sided here. And so we're really going to look for more global representation. And because we are using an academic institution, and this will go into a REGCAP database, for the first time, the IASLC members, particularly the Staging and Prognostic Factors Committee, will be able to mine this database. They could not do it with the CRAB database because it was a proprietary database. So I'm really excited about that for our members. And then we hope to be able to collect some pathology slides and some radiology images to do some additional sub-study work, as we've all been talking about AI in particular. And then we are working on right now, even though this is listed here, is to have a staging mobile app that can calculate. If you're in the 8th edition, it's hard in this time period when we're transitioning to go from the 8th to the 9th. So we're going to come up with we're working on a calculator that can just put the information in on the 8th and it will calculate for the 9th, particularly for clinical trials as well. That'll be very helpful. So we're trying to learn new lessons. Now, the chair of the 10th staging committee is Valerie Roosh, and Ray O is our deputy chair, and he will be the chair of the 11th. Even though we're talking about the 10th, we're actually talking about the 11th at the same time. This is a large undertaking by the IASLC. I'm just showing you this to just show you the complexity, and Valerie and Ray have done a great job making sure the committee is well represented by, our 3 factors of gender, disciplines, and geographic location. And this is not easy to do. And this is a large committee, but they did a great job of paring that down as well. So just to show you that does take a lot here. So here are my questions that I have, and Ray knows this very well because I keep tasking them with, what do physicians and patients really want from us in the 10th edition to help them optimize care? So that's number one. And then that's what they want. We're researchers, and sometimes what do we think they want? And hopefully they would match. So we kind of have, a lot more things on our list, but really what are the gaps and how are we going to address them? And particularly, how do we think about prognostic factors today in an untraditional way? All right, maybe we need to go to a more dynamic treatment modulated prognostic factors. And so with that, I'm going to stop because I'm really wanting to hear the other speakers and their perspective. Thank you so much.